Hello, in this video we will demonstrate proper positioning and technical considerations for the selected patella and shoulder radiographic projections. For each projection, we will briefly explain the clinical indications, technical factors, patient positioning, image-receptor relationship, central ray placement, and shielding practices. We will begin with the PA patella projection, which is used to evaluate the patella for fractures, alignment, and joint pathology. When it comes to setting up the consult for this exam, you want to ensure that you select the tabletop option and set your own technique of 55 at 2.5. Patient positioning for this exam is going to have the patient laying prone on the table with the affected leg extended out and relaxed. You'll then take the cassette out of the bucky, as no grid is used for this exam, and you'll place it underneath the affected knee. It's important to note that according to Bontrager, no gonadal shielding is used as it may obscure anatomy and does not significantly reduce the dose. We're going to be using an IR size of 8 by 10 inches place portrait, and you'll ensure that there's a 40-inch SID. The patella is positioned parallel to the IR with no rotation of the knee, and the central ray is placed perpendicular and centered to the mid-patella, where you'll then mark the correct side of the body. Now for the image evaluation of the PA patella. According to Bontrager, you were supposed to use a KVP of 55 with no grid and an MAS of 2 with an SID of 40 inches. According to the book, the anatomy on the image is supposed to demonstrate the knee joint and patella with optimal recorded detail of patella because of decreased OID if taken as a PA projection, which you can see in our image is met. According to positioning, no rotation is present, evidenced by symmetric appearance of the condyles, which you can see here. In our image, we have both the medial condyle and the lateral condyle showing as symmetrical. The patella is centered to the femur with correct slight internal rotation of the anterior knee, and the patella is in the center of the collimation field, which both criteria are met in our image. As you can see here on the left, we do show that the patella is at the center of our image. According to the exposure factors needed, optimal image receptor exposure and contrast with no motion demonstrates clear, sharp bony trabecular markings and outline of patella as seen through distal femur, which is met in our image. And then some other anatomy demonstrated on our image here. In the center and the distal aspect of the patella, we do have the femoral orbital joint space. And then there's also just next to the patella on both sides, we have the medial epicondyle and then the lateral epicondyle as well. Next, we'll be demonstrating a lateral patella projection where we'll be setting our own technique of 57 at 2.5 and using an IR size of 8 by 10 inches place landscape. No grid is used for this projection. You're to instruct the patient to lay in a lateral recumbent position with the affected side down and flexing the knee 5 to 10 degrees to prevent patellar displacement. Ensure there is a 40-inch SID. For this position, the patella is positioned perpendicular to the IR with the femoral condyle superimposed. The CR is perpendicular and centered to the mid-patella, and no shielding is used per department protocol. Ensure that you mark the affected knee. And collimate to include the patella and distal femur. When it comes to the lateral patella, our book demonstrates that we need a KVP of 57 and an MAS of 2.5 with no grid being used. We also have an SID of 40 inches. For the anatomy demonstrated, we need the profile images of patella, patellofemoral joint, and femoral orbital joints are demonstrated, which in our image here on the left, we can see the patella clearly along with the patella femoral joint and the femoral orbital joint space are all demonstrated here. Positioning requirements for a true lateral include the anterior and posterior borders of medial and lateral femoral condyles should be directly superimposed, and patellofemoral joint space should be open, which is demonstrated on our image. We also need the centering and angulation to be correct if patella is in the center of the film and collimated field with joint spaces open, which is also demonstrated on the left. As far as exposure factors, we need optimal image receptor exposure and contrast to visualize soft tissue detail and patella without overexposure. We also need trabecular markings of the patella and other bones should appear clear and sharp, which is also demonstrated. Here we are setting up for the Settegast projection, where we'll continue to use the tabletop option as no grid is required, and we'll set our own technique of 57 at 2.5. The IR size is 8 by 10 inches. The central ray is angled 15 to 20 degrees cephalad directed through the patellofemoral joint space, and the patient is positioned prone with the knee flexed 90 degrees, depending on the patient tolerance. The patella is positioned perpendicular to the IR with the femur and tibia angled due to knee flexion. Ensure that you collimate to the patellofemoral joint space only and that there is a 40-inch SID. Mark the affected side. No shielding is used to avoid obscuring anatomy. Next, we have the Settegast patella evaluation. Our book recommends that we use a KVP of 55 and an MAS of 2. No grid is required, and an SID of 40 inches should be used. For the anatomy demonstrated, we need the intercondylar sulcus, which is also called the trochlear groove, and patella of each distal femur should be visualized in profile with patellofemoral joint space open, no superimposition of the patella or tibial tuberosities. This is demonstrated on our film here. As you can see, the floating patella, and then the more proximal end of it, you can see the articular surface, which articulates with the patella surface. Here we have the femur, and then on the right side of the image, we have the medial femoral condyle, and then on the left side of the image is the lateral femoral condyle. Positioning requirements require that no rotation of the knee to be present, as evidenced by symmetric appearance of patella, anterior femur condyles, and intercondylar sulcus. This is met on our image. We also need correct CR angle and centering to be evidenced by open patellofemoral joint space, which you can see here as well. Lastly, the exposure factors that are required for the Settegast patella include optimal image receptor exposure and contrast to visualize soft tissue and joint space margins and trabecular markings of the patella. And we also need our femur condyles to appear underexposed with only the anterior margins clearly defined on the image, and this is all met on our image evaluation. For the AP external shoulder projection, we'll be using a table option as a grid is going to be used, and we'll be setting our own technique of 70 at 3.2. The patient is to lay supine on the table so that the posterior shoulder is closest to the IR. We'll be using an IR size of 10 by 12 inches placed portrait and a 40-inch SID. The central ray is perpendicular, centered 1 inch inferior to the coracoid process. Ensure that you're collimating to include the proximal humerus and the scapulohumeral joint. The arm is externally rotated so the epicondyles are parallel to the IR, placing the humeral head parallel to the detector. Next, we'll be evaluating the criteria needed for an AP shoulder with external rotation. As far as technique, Von Traeger recommends that we use a KVP of 70 and an MAS of 2.4. A grid should also be used, and we have an SID of 40 inches. Anatomy demonstrated on this film for an AP projection will need a proximal humerus and lateral 2/3 of the clavicle and upper scapula to be included. We'll also need to include the relationship of the humeral head and glenoid cavity. Positioning requirements include full external rotation to be evidenced by greater tubercle visualized in full profile on the lateral aspect of the proximal humerus. Lesser tubercle is superimposed over humeral head, and collimation field size to the area of interest. Going over to our image here on the right, we do see that the greater tubercle is in profile along with the relationship of the head of the humerus within the scapulohumeral joint space. Just distally to that, we do have the proximal humerus, and then going more proximal, we have the acromion located superior to the greater tubercle, and then the coracoid process located more proximal. Lastly, we need to go over the exposure for this projection. We do need to have optimal image receptor exposure and contrast with no motion, demonstrate clear, sharp, bony trabecular markings with soft tissue detail visible for possible calcium deposits. This is also made clear on our image here on the right. We'll set up for the superior-inferior axial shoulder projection, selecting the tabletop option and setting a technique of 60 at 6.3. A grid must be used for this projection, so we'll put that on our cassette, and we'll be using an IR size of 10 to 12 inches. The patient is seated upright with the IR placed posterior to the affected shoulder, and we'll have our patient lean slightly towards the affected side, while also tilting their head away from the affected shoulder. Ensure there is a 40-inch SID and a central ray angled 5 to 15 degrees medially. Ensure that the central ray is entering superior to the shoulder joint and directed inferiorly through the glenoid humeral joint. Mark the affected side. The shoulder joint is positioned parallel to the IR with the humerus in a neutral position. No shielding is used per current Bontrager guidelines. Next, we'll be going over the criteria for a superior-inferior shoulder projection. Bontrager recommends that we use a technique of 55 kbp with an MAS of 6.3. We'll also be using a grid and an SID of 40 inches. The anatomy demonstrated requires a lateral view of a proximal humerus in relationship to the scapulohumeral, or also known as glenoid humeral articulation, to be visualized. We also are required to have the coracoid process of the scapula seen on the end. Both of these anatomy requirements are met on our image. I'm going to go over here on the right. You can see on the most lateral aspect of the image, we do have the humerus. Going more proximally and inferior, we have the acromion. Just superior and slightly more proximal to that is the lesser tubercle. And then more proximal to that, we have the scapulohumeral joint space. Proximal to that is the clavicle, and then proximal and superior, we have the coracoid process demonstrated. Positioning considerations include the arm to be abducted away from the body, which is present on our film. We have the relationship of the humeral head and glenoid cavity should be evident, which is demonstrated on our image. And then collimation field size to the area of interest is also met. Lastly, exposure criteria includes optimal image receptor exposure and contrast with no motion demonstrates clear, sharp, bony trabecular markings and pertinent soft tissue anatomy. This requirement is met on our image. And lastly, we have bony margins of the acromion and coracoid process are visible through the humeral head, which is also demonstrated. So we'll set up for the Lawrence method of the shoulder, which is also called the inferior-superior projection. We'll be selecting the cassette option and setting our own technique of 60 at 6.3. Here we'll be taking the cassette out of the bucky and placing our own grid on it. A field size of 10 by 12 inches is recommended for this projection. And once the grid is on, we will then place it in the cassette holder. The patient is positioned supine, where you'll have them roll away from the affected side to place a towel underneath the affected shoulder. This will allow for a better visualization of the shoulder joint on the x-ray. We'll then place the IR behind the shoulder and have the patient roll their head away from the affected side, abducting their arm 90 degrees. The central ray is placed perpendicular to the IR, and a 15 to 30 degree medial angle is placed on the CR. We're going to direct the CR through the axilla towards the AC joint. The shoulder joint is placed parallel to the IR, which is placed superior to the shoulder. We'll then mark the affected side and collimate tightly to the shoulder joint. Lastly, we will go over the criteria for an inferior-superior axial shoulder. Bontrager recommends we use a technique of 60 kVp at 6.3 MAS with a grid and a 40-inch SID. Anatomy demonstrated on this image include a lateral view of proximal humerus in relationship to scapulohumeral cavity. Coracoid process of scapula and lesser tubercle of the humerus are seen in profile, and the spine of the scapula is seen on the edge below the scapulohumeral joint. All of these anatomy are demonstrated on our image. Starting with the most distal piece of anatomy here, we have the acromion, which is located superior to the humeral head. More proximally and superior to that is the spine of the scapula. Just distal to the spine of the scapula, we have the glenoid fossa, which the humeral head sits in, and just below that is the lesser tubercle. More proximal to that, we have the coracoid process, and then just to the right of that is going to be the clavicle. Positioning criteria include the arm to be abducted approximately 90 degrees from the body, which is met in our image. The superior and inferior borders of the glenoid cavity should be directly superimposed, indicating correct CR angle. This is also met. And lastly, we need collimation field size to the area of interest, which is also met. Lastly, we're going to go over exposure criteria for this image. We do need to have optimal image receptor exposure and contrast with no motion demonstrates clear, sharp, bony trabecular markings. This is also met on our image. And we also need to have bony margins of the acromion and distal clavicle to be visible through the humeral head, which is also demonstrated. Thank you all for watching our presentation on patella and shoulder projections. Please let us know if you have any questions.
Going. So it doesn't actually have to be for, this is for TV.
Oh my gosh, that looked so good.
So professional. And now you want to record me laying down?
Yeah.
No, yeah, so what you guys do is just go kind of walk up, tell her to lay down.
Yeah, okay.
So it's just kind of like, yep. And what you do is just kind of start from back there, just kind of walk up to it and then have her lay down.
Okay.
And I'll do it all from right here.
Okay, let me know when.
You guys ready?
Yeah.